break. Hope you've had a chance to certainly reflect on our wonderful first presentation, and we're so excited to move on to our second presentation of the conference today, Memory Loss in the African Immigrant Community. And I am so thrilled to have two very close colleagues presenting here today on this really important topic. I think, as many of you know, in this conference each year we have always tried to pay attention to issues related to diversity, equity, inclusion as it relates to memory loss, caring for people living with dementia, et cetera. And one community in the state of Minnesota that has been a focus of some of our recent work, and particularly the work of our next group of presenters, is on memory loss in the African immigrant community. And so we have with us here today Dr. Manka Nkimbeng, who's an assistant professor in the Division of Health Policy and Management here at the University of Minnesota in the School of Public Health, and my colleague. She has led and co-led a project since 2019 to better understand the needs and resources in the African immigrant community, particularly in the Brooklyn Park area and that region, and really with a goal and focus of developing and refining educational resources for these communities that are co-created with the community. In addition to Dr. Nkimbeng, we also have Mr. Wynfred Russell, who has earned his Master's of Public Health here from the University of Minnesota School of Public Health, I'm proud to note. He's also on the City Council of Brooklyn Park and has been working closely with us to make this a very important project, one of the first of its kind in America, a reality. So I'll turn it over to Dr. Nkimbeng. Thanks, Manka.
Good morning, everyone. Thanks so much, Dr. Gogla, for the wonderful introduction. And so we'll be talking about memory loss in the African immigrant community. As you can hear from my accent, I am an African immigrant myself, and let's see. Technology here. The clicker seems not to be working. If we can just go to the next slide. Okay, perfect. So a little bit of background about kind of what's happening with this community. So we know that with technology and kind of the modernization of healthcare and medicine, a lot of Africans are not longer suffering from, infectious diseases such as diarrhea and all of the other things that used to cut their life expectancy short. So we have a lot of Africans that are living longer and living into older adulthood. And so a lot of those people now are actually facing the risk of the age-related conditions such as dementia and memory loss. And then we also find that a lot of the African immigrants who came to the United States in the 80s and 90s, they came as adults, in their 30s and 40s, and now aging in the United States. And so we're getting a higher number of older adults in the African immigrant community. And then the third thing we know as background is that there's a higher burden of dementia and cognitive diseases in racial and ethnic minority communities. So we have Black Americans having a 2 times higher risk of dementia, and we have Hispanic and Latino older adults having a 1.5 times higher risk. And in addition to kind of all of these things that are happening, we understand that healthcare infrastructure in a lot of African countries is really poor. There's a limited number of providers and specialists, especially geriatricians. There are quite a few countries that you can actually count the number of geriatricians in maybe even one hand, so there's really a limited number of geriatricians in a lot of African immigrant countries. We find that healthcare infrastructure in a lot of African immigrant countries do not have the sophisticated technology and resources to provide services for age-related conditions. And then we have also in the United States, cultural challenges that impact care for racial and ethnic minority communities. So we have kind of a limited number of culturally diverse providers. We have things like structural discrimination and racism that impact access to care. And on top of all of those things, then we have immigrant-related challenges, such as coming from a country or a system where there was no preventative health care, there was no primary care visits. And so we have all of those things that are affecting and playing a role for the health of African immigrants in the United States, especially the older adults. And so with all of that in context and with all of that happening, there was then the reason or the need for a project such as the African Immigrant Memory Loss Project, which is the project that we're undertaking that Dr. Gogler was talking about. And really to talk about why there is a need for such a project, I'll bring on Mr. Wynfred Russell, who was actually part of the creation of this project, to talk about it a little bit more.
Thank you. Thank you, Dr. Nkimbeng and Dr. Gogler. It is great to be here with you all, and this is a wonderful time, a wonderful experience working with the University of Minnesota School of Public Health with Dr. Gogler and his team in trying to understand deeply the connections between dementia, memory loss, and its impact within the African immigrant community. So to just give you a little bit of background, I am the founder of a community-based organization that is based in Brooklyn Park in the northwest suburbs. It's called ACER, and ACER stands for African Career, Education, and Resources Incorporated. And so what ACER is striving to do is to try to close the resource gaps within Minnesota when it comes to people of color, especially folks of African immigrant descent. So there are a lot of disparities, as we all know, within the healthcare sector, within the economy, and education. There were so many different gaps, and so we founded ACER as a way to help to close those gaps. So we know of all of the social determinants of health that are impacting our folks and keeping our folks not being able to live lives within their full potential, live the quality of life that they deserve. So we've been working with Minnesota Department of Health, with the University of Minnesota in trying to see how best we can come up with projects to help to close all of the various gaps across our community that we have. And of course, one is health and public health. So we're very grateful to the university again for working with us in trying to understand the deep ends of dementia and memory loss within our community. So there was a student at the University of Minnesota, I believe he was from Uganda, so who then put us in touch with Dr. Gogler. Dr. Gogler, being who he is, who always wanting to ensure that his research and his work is anchored within the community, reach out to us, and so we connected, and it's been a very wonderful experience working with Dr. Gogler and his team. And the great thing about it is that we have been able to work on this project and being brought on today's working with the university from not from a deficit standpoint, but from a standpoint of where we are bringing in some knowledge. We are contributing to the research. So I'm co-PI on the project with Dr. Nkimbeng and Dr. Gogler. So all of us, so the community perspective, the community input is just as equally important as the academic and the research input coming from the University of Minnesota. So we have been thrilled on that aspect of it, because many of the projects, research projects, so it's not a matter of coming into the community and trying to extract information from the community, but how do we work with the community in trying to understand some of the issues and some of the barriers that that exist within the community. And so we talked about dementia and the prevalence of dementia or lack thereof within the African immigrant community. And so there was something that we really wanted to understand, wanted to understand a great deal about, because I have a personal experience with that too as well. That's not why we decided to work on this, but it just came in handy that that my personal experience, was also, brought to the table. It helped to inform my decision and my interaction with the team from the University of Minnesota. My maternal uncle is battling dementia, and when it first started, we had no idea as to what was going on, and from the cultural context, I'm originally from Liberia, so I'm a Liberian immigrant. So many of us don't understand what dementia is. So it's very easy most time for folks to just dismiss it as being you're either crazy, or the person is going cuckoo, or they have maybe some mental health issue. They really do, many folks really don't understand, including myself, before I joined this project, understand what dementia is and what the impact is having within our community. Personally, I know at least about 5 or 6 family members, families within the larger community, folks who are dealing with relatives of loved ones who have dementia. So, understanding that, and trying to at least bring the community together and try to get their perspective, and try to, especially from the perspective of those who are providing care to people with dementia, I think it's critically important to this project and to our understanding as to how we can come up with interventions and solutions, and what kind of policy can we try to push to help to provide more care and more support to people who are living with dementia and memory loss within our community. And I've seen, see my family, my uncle now is back in Africa, and things are slightly different, and so it'll be a good thing to also understand those environmental factors that may come to play to exacerbate folks with dementia, either within this context here in the West, or back in Africa. But it really disrupted our family, and trying to understand how to care for him. He lived with me, so I had direct personal experience. Have to change the door locks. We have to change a lot of things, and it happened so fast. And then while talking to other family members and other folks within the community, trying to compare notes and understand, so okay, so this is not just happening in my family, but it's happening in several other families, across the board. And so this is this research study. This project has given us a lot of insight as to how to what dementia is all about, and how to care for people with dementia, and also how to provide support to caregivers who are providing care to people who are suffering from dementia, or who have, those who have early memory loss. So thanks again for the opportunity, but I'm glad to be here, and we will be sharing more with you about what we're doing with this project within the African immigrant community as a whole. Thank you.
Thanks so much, Mr. Russell, for sharing your personal experiences. And so we'll talk now about the project itself. And so, like Mr. Russell was saying, the African Immigrant Memory Loss Project is really a university or community university partnership, and it's a partnership between the University of Minnesota School of Public Health and ACER. And the project is community informed, and is actually guided and directed by a project advisory board, which is made up of about 20 community advocates and stakeholders. And one of our community project advisory board members is actually with us today, so feel free to ask her questions about her experiences on the PAB, in addition to questions about memory loss in the African immigrant community. And for people who are interested in the research methods, it's a sequential exploratory mixed methods, which basically means that we started with qualitative data collection, and we're gonna end with quantitative data collection. It's very sensitive. And so the project started in August of 2019, and we've had quite a few project advisory board meetings since then. The project advisory board has guided the development of every thing that we're working on. I think I might have missed this. I'm sorry about that. The project advisory board has guided the development of everything that we're using, our instruments, our data collection tools, and the project advisory board is actually part of the data collection team. So we've had 3 community conversations and 2 interviews, and the interviews were actually set up as community conversations, but unfortunately, since the other members did not show up, and so we're just able to interview the individuals, the one individual that showed up in those 2 interviews. And so the community conversations happened in the community. We had them at the city council, thanks to Councilman Russell's connection at this Brooklyn Park City Hall. We've had them at different churches that our project advisory board members attend. The project is community-based and is community-informed, and everything is happening with and in the community. And so we've had 3 community conversations. And so we'll talk about some of the preliminary findings from the community conversation. So we find that out of the 24 people that we've spoken to in total in the first phase of the project, 19 of them were from Liberia. And that makes sense because Liberian immigrants are the majority in the areas in which we're working with, which is the northwest suburbs of Minneapolis. We find that females, about 15 female participants in our community conversations out of the 24. The age, we have a decent sample of older adults, so the majority of them were actually over the age of 55, which is something that we're really happy with because we're hoping to get the perspective of older adults in the community. And for education, we find that the majority of our participants were highly educated, but this is not strange. The majority of African immigrants in the United States have at least a bachelor's degree. So out of our sample of 24 participants, we had about 18 of them having a bachelor's or graduate degree, and 1 person chose not to report their education status. Sorry, this mouse is very... And so we'll now move to kind of what we're finding out about the experiences in the community. So like Councilman Russell was talking about, we see that memory loss is gradually becoming something that is of importance and something that people were witnessing in the community. Like the quote on the left-hand side talked about how the participant was mentioning that they've begun seeing an increasing number of people having memory loss in the community. And then there was another participant that mentioned that they know people personally in the African immigrant community who had memory loss. And then when we asked participants to talk to us about kind of things that are related to the medical condition itself and traditional management in the United States, we found that a lot of people were able to identify the symptoms of memory loss and dementia. They talked about forgetfulness, they talked about difficulty managing activities of daily living, and then they talked about difficulty having conversations with relatives and people in the homes. And then when he talked about how to diagnose memory loss, there was a lot of participants who were able to describe how diagnosing dementia and the condition itself is not something that happens at one point in time. It's a slow process of observation and kind of assessment to make sure that you give the diagnosis after a long time of understanding the person's behavior and activities and needs. And then when they describe management, participants identify the things that we know in the literature, such as medical management. They talked about being able to help participants with activities of daily living, and they were describing those as proactive measures. And then they identified emotional support that is needed and how to communicate with the participant. And they talked about also alternative remedies, which is participants were identifying things like taking supplements to be able to help with memory. And then when we asked participants to describe kind of management approaches that were maybe a little more African or related to the African culture, participants really talked about how there was a cultural expectation of family care. And they described the fact that memory loss in the African immigrant context traditionally happens in the family. So family members were caring for a relative who has memory loss or dementia. They talked about the fact that this care is happening in the home, and they typically were hesitant to take their relative or family member to a facility such as an assisted living or nursing home. And then they also mentioned that caring for a relative with memory loss, unfortunately, is people are very secretive about it, and we can know that being secretive about healthcare itself could be a challenge as well. And then the other aspect that participants talked about was describing the fact that because it's expected to care for a family member in the family and in the home, memory loss itself is not a big deal. It's just another aspect of care that one has to provide for a relative. And then the last thing that participants talked about that was happening that's relevant to caring in the African immigrant context was the fact that families could decide to send a relative with memory loss or dementia actually back home to their country of origin. And as we remembered, Mr. Russell talking about his uncle going back home to get care in their country of origin, which is Liberia. And then when we talk about general health care and we're asking about health promotion activities for members of the community, people talked about the traditional things that we know. We talked about the need for people in the community to have a primary care provider and also to follow up with that primary care provider frequently or as needed. And then participants described something which was very interesting. A lot of our participants described the need to talk about end-of-life challenges, especially with somebody who has memory loss or dementia, or talk about developing an advance directive and all of those end-of-life care issues. But a lot of them who described this and talked about the need for it actually had not done it themselves. And then most of our participants also identified the need to get diagnosed early if a relative had dementia or memory loss. But unfortunately, this was also something that we find in the literature that is not common in racial and ethnic minority communities. Unfortunately, they often get diagnosed later in the disease stage. And then when we asked our community members what their educational needs were, they identified the typical things that are common. Participants wanted us to develop and offer education about the science of the disease and the pathology of the disease, talk about the progression of the disease and the various stages. They wanted us to offer education about normalizing care. This is normalizing care for dementia and also just normalizing regular care such as attending primary care provider visits. And a lot of participants talked about stigma, and they mentioned that if people were able to understand the disease process better, then it might also decrease stigma in the community. And a lot of the participants described that there was a lot of myths in the community, and so there was a need for education to talk about what are really the true risk factors of dementia and what are really the true strategies that are evidence-based to be able to prevent and improve cognitive function in later life. And then participants also asked for education related to the management, how to seek care, where to get care, how to communicate with a relative with memory loss, and also they talked about a need for access to resources. A lot of the participants did not know who the geriatricians were in the community, where they can go get an assessment, who they can talk to, or really who they can turn to if they found out that a family member was having memory loss and they wanted to get assessed or diagnosed for dementia. And then the next thing that we asked in the community conversations was for participants to identify barriers to getting care for dementia. And so participants identified quite a few challenges. The first one is that participants described the fact that there was not a lot of many culturally diverse providers in the United States, and so that was a barrier for providers who might have been for families who might be seeking a provider that is the same racial, ethnic, or cultural background as them. And then participants described this kind of cultural kind of issues that might limit awareness of memory loss, and this is stemming from the fact that a lot of participants were describing to us or to the interview was that they had not heard of memory loss or dementia until they came to the United States. And so if you really do not know what it is, you are not able to understand or recognize the symptoms that somebody is suffering with, and then you're not able to, if you're not able to recognize that, you might not even be able to bring it up at a doctor's appointment or a doctor's office. So they describe these kind of cultural issues that were limiting access or awareness of memory loss in the community. And then a lot of participants brought up the fact that there was some fear or mistrust in the US healthcare system. And it's for the typical things that we've heard of in the past: racism, kind of history of injustice that has happened for racial and ethnic minority communities. Another big barrier that participants identified was financial resources. So participants described that for those who had a relative who had memory loss or dementia, they had no finances to be able to provide care for them, either at home by getting a home health aide or nurse to come into the home, or they actually had no finances or money to get care for them in an assisted living or nursing facility. I am so sorry, this clicker is very sensitive. Okay. So the other barriers that people identified were things like multiple responsibilities, and we've heard this a lot about caregivers for people caring for people with memory loss and dementia. They talked about multiple responsibilities such as needing to work, having school-age children, or having to go to school themselves and still provide the needed care for a relative who has memory loss or dementia. And then we talked a little bit about the cultural awareness, which was related to the lack of knowledge about the condition and the services that are available for this condition in the healthcare system. And for immigrants who do not speak English, another barrier was language, where a lot of them talked about not being able to speak English, and then in addition to that, being afraid to go to the doctor, or going to the doctor and not being able to speak English and not having an interpreter available. And even people who were able to speak English also identified the fact that there was accent-related issues where providers were reporting that they were not understanding their accents, and so that was to a language breakdown between the provider and the family. And then a lot of participants identified that because of immigrant status, some people who might not have legal status might be afraid to go to a provider. But also, if you don't have legal status, you don't have access to healthcare insurance, or for older adults, if you had not been in the US for a long time, you might not be able to access Medicare or other forms of public available or as subsidized healthcare plans that are necessary to provide healthcare for people who are low income. And then again, the general lack of health insurance or medical insurance was identified as a barrier to getting care from dementia or memory loss. And then we also asked participants to identify resources in the community. And like we're talking about, this project is not just a deficit-based approach. We wanted to also identify the assets that were already in the community. And participants identified a lot of assets in the community. They talked a lot about country-level organizations that were in the community that were providing different types of resources and help to members in the community. They talked about church and religious organizations, businesses and not-for-profits like ACER that was actually working with us to do this project. They talked a lot about professional organizations such as the Liberian Nurses Association, the Nigerian Nurses Association, the Sierra Leonean Nurses Association, and quite a few of these associations were going around providing blood pressure assessment, providing medication management to a lot of older adults in their homes. They talked about some of these organizations also providing rides to churches and other social services, or like bringing some participants to daycare and other things that might help them improve socialization. And then they talked about how there were some community organizations that were actually offering support groups and adult day service programs in the community. And again, all of these community organizations were providing different forms of education, seminars, and webinars for these participants. But the biggest thing that participants talked about, which was a need, was that all of these services are actually not coordinated, and also many people, if you were not in that community, you would not know about the services. So there were some resources in the community, but a lot of people were not aware of them if you were not in that unique community. And then participants also talked to us about some attitudes that are kind of immigrant related that could also affect care and care seeking. One of the big attitudes was that participants were saying that in the African immigrant community, there's a general kind of attitude that is related to avoidance of bad news and death. And so participants were saying that if I were to have memory loss and then go get a diagnosis of dementia, what's the point when I know that it's going to lead to death? And so it was kind of this thing where what you don't know doesn't hurt you. And so people were describing this attitude being pervasive in the community. And then another attitude that participants were talking about was the fact that care in a U.S. facility such as an assisted living or a nursing home is actually the last resort. So we talked about how participants were saying that family care happens in the home, but in participants who have this kind of multiple responsibilities and that they're not able to provide care to a relative because of their child, work and other responsibilities, they really describe that going to a facility to get care is actually the last resort. And we know that that could be a good or a bad thing, because if a participant's at home and then, if a person with memory loss is at home and they're not getting the care that they need, it might not be a good thing for them, even though they're at home in the family. Then again, we talked about the attitude of limited trust in the healthcare system stemming from a lot of history and also newness of the healthcare system. Like we mentioned earlier, a lot of people coming from different African countries do not have the sophisticated medical systems that we have in the US. And so if you do not know what is available to you in the healthcare system, then you might not trust it, or you might not even access it. And then another attitude that we found that participants were describing was kind of this spiritual cause of dementia, where some people were identifying that dementia might be caused by bewitchment, or if you're crazy, you might, if you have dementia, you might be crazy, or some sort of witchcraft that has been put or befalls you. And so this was an attitude that participants described that could also be impacting stigma and also access to services, that people might be afraid that this is what is happening to them, and so will be reluctant to seek care. And participants in general actually talked about, the more knowledge you have about dementia, the risk factors and what the disease is, the less stigmatized it's going to be. And that's one of the reasons why a lot of our project advisory board, community members at the community conversations, at the end of every community conversation, they'll come to us and say, we need education that is going to help decrease the stigma. And then in addition to kind of the spiritual causes related to dementia, there was a general lack of awareness related to mental health illness, and actually dementia for some people was actually lumped together with mental health. And in several African immigrant dialects, the term that is used to refer to somebody with dementia is actually a general term that is referring to people who have mental health illness. And then a little bit more about the immigrant attitudes that affect care. One of the things was that people were talking about, like you see, some people are sending their family members back home to get care. And so they talk about kind of what kind of care you can get if you're in Africa, or if you send your relative back to an African country. So a lot of people talked about there would be a lot of help back in Africa, because there's a lot of family members and a lot of community there available to provide more care, kind of more one-on-one supervision and all of the things that a person living with dementia or memory loss might need. But they also identify the fact that there are no facilities back home, so care is going to happen in the home, which a lot of participants were kind of ambivalent about. It wasn't necessarily a good thing or a bad thing, it was just kind of a matter of fact. So if you were to need a facility back home in Africa, you would not get one, and so the care was going to happen in the home. And then the last thing that it talked about was kind of this limited healthcare infrastructure. So it will be difficult to diagnose a family member with memory loss in your country of origin. But if also the person with memory loss were to be in the country of origin, participants identify the fact that they might not get kind of more acute, more upgraded kind of healthcare services if they needed to. So if you were to send a relative back home and then they got sick and they had something, they might not be able to access the care that they need because of the limited healthcare infrastructure in a lot of the African countries that participants came from. Okay, so with kind of what we found, I would like our project advisory board member, Ms. Labelle Nabangi, to talk a little bit about kind of the implications of what we're finding, what she's been on our project advisory board, and she's been part of the team that is really guiding us to do this work. And so once she talks, we'll now try to look and see what questions you have, and we'll begin to answer your questions.
Hello, everyone. Good morning. I'm Labelle Nkimbeng, and I've been with this project from the start. Over the years, I've had to work with a lot of different African immigrant communities in the Twin Cities through an organization, and I worked a lot with the high school students. And so from a community perspective, one of the things that's affecting the younger ones or the high school students is the fact that some of the help is needed from them, the care. So mom has to go to work or dad has to go to work, and the young teenager has to be back from school and take care of the adult at home, the grandparent who is facing some memory loss challenges. There is language barrier, as most of the kids born out here do not speak their mother tongue. And so the parents usually act as the interpreters while they're home. But in the absence of when the parent is at work, these kids can barely talk to their grandparents. And so they just try to understand, which is really hard to do most times. And so they have that issue already, and they're not really happy being put in a position where they have to provide this care as often as they have to do. Another implication is that of family members having to take shorter hours at work just to come back home and stay with the parents. As Dr. Nkimbeng earlier mentioned in the presentation, there is very little help, lack of finances, and you have to depend within the family. And so that is already a huge financial burden on these family members who have to take shorter hours at work. The issue of sending family members to the nursing homes is also something that is not yet accepted within the community, as it's considered inappropriate within the culture. And so one or two families that have done that have been labeled like bad. They've become too Americanized. They've forgotten where they came from, and they're trying to pick up ways which are not theirs. So they face a lot of, accusations from community members. They've been ostracized. It's a lot of difficulties happening at the same time. So those are some of the implications we've seen so far with the issue of memory loss. And then again, of course, it's not considered dementia or an illness. Most times it's assumed as people get older, they start to forget things. Or again, it could be a curse, someone is trying to do you in. So it's not taken as seriously as it should be. So it will be very helpful with this project as it continues for the education piece, as people need that, because it's becoming a little bit more rampant within each of the African communities to have families who have older family members suffering from some form of memory loss.
Thank you so much, Ms. LaBelle. So we have a couple of questions here. So the first one is, how could I, as a non-immigrant, become involved in your project? Thank you so much for that question and your willingness to volunteer. I don't think my email is on the slide, but my email is manka@umn.edu, or you can reach out to Dr. Gogler. Any of us, we're part of the project, and so we'll be able to talk to you a little bit more about, see what your interests are and how you can help us as we go along in this project. And then the next question is, wondering if you would tell us more about sending family home to the country of origin. Why is this done? Thinking more trust in home country healthcare or help from other family? Is it related to stigma? This is a very good question, and I can have Mr. Russell take a first stab at it, and then maybe I can add in.
Yeah, thanks. That's that's really interesting. So, I called Manka, I think a couple of weeks ago. So my uncle, as I shared with you, my uncle has been having really difficult time here, and so the care for him has been shared among all of us, all of his nieces and nephews and kids here in Minnesota, and he has a son out in Arizona. And so one of the things that we noticed, for example, is that his short-term memory is completely gone. I mean, he doesn't recognize, or he didn't recognize any of us, even though he lived with me. But it came a time that he wouldn't recognize me, and even his biological kids, he wouldn't even recognize them. And so he was having a really difficult time. And so we got our aunt, his ex-wife actually, to help provide care. And so all of the commotion and all of the problems that happened with them that caused them to divorce in the first place, all of that came back. And so when she was taking care of him, he would attack her, and he would, even took at one point a knife on her. And so it became very alarming, and we're very disturbed by it. I mean, a lot of things that, so he bringing back, it seemed like a lot of those memories from the past, and bringing it, using some of the same words. And so it got to the point where my aunt was very skeptical of the fact that they said, well, I don't think he has memory loss. I don't think he has is developing dementia or something. I think this is personal. I think he's trying to attack me. And so we tried to explain to to her, and especially with my involvement in the project, so we were able to at least understand some how memory loss, how this happening, and how it comes upon folks, and some of the symptoms and all of that. And so we, because of the difficulty in trying to care for him here, and bouncing from one family member to the other, and then when our aunt tried to take care of him and had this sort of violent reaction from him, so we decided to send him back to Liberia, his country of origin. And so we sent him back to Liberia. When he was here, he wasn't eating. I mean, he was having a difficult time, adjusting, and just trying to leave the house in the middle of the night. In fact, at Brooklyn Park, the police picked him up at 1 o'clock in the morning, walking around the streets there in Brooklyn Park. And luckily, they were able to call me. They had my cell phone. They were able to call me to go and get him. So of course we had to change all of the locks, and it was just really, really difficult. But then when we sent him back to Liberia, and the only reason why we sent him back to Liberia was because of the difficulty in trying to provide care for him here, different family members to take care of him, because the only family member, the only person that at least had the time to take care of him was his ex-wife, but she didn't want to do it again because of the way he reacted to her, and he was being very violent to her and all of that. But when we sent him back to Liberia, things changed. Things start to change. I'm not saying that he's killed or anything, but his attitude was completely different. I mean, he's beginning to recognize us. Things were like remarkably different in Liberia than it was here. And I remember before he started to lose a lot of his memory, one of the things that he couldn't wait to get retired and then go back home to go to his house and all of that. So when it became difficult to care for him here, we said, okay, you know what? Let's just honor his wish by taking him back home, so he live in his house, and so he can be there. So we renovated the house, and took him back there, and things changed. He's acting differently. I mean, he's doing a hell of a lot better than he was here in the U.S. And then a couple of weeks ago, I got a call from a friend of mine who called me from Ohio, was trying to ask me for a favor, and I said, okay. And so while talking, and then she brought up the situation of George Floyd and where that took place. And she's like, my mother-in-law used to live there. And I said, oh, really? I said, okay, so how is she doing now? I said, she's fine. She no longer lives there. She's back in Liberia. We sent her back to Liberia. She said, oh. And then she told me, she's like, she has started developing some symptoms of dementia, and it was very difficult caring for her here. and she was beginning to lose her memory, and she was doing a lot of things that just borderline psychotic. And so the family decided to send her back to Liberia, and we sent her back to Liberia. And all of a sudden she's killed. And I said, what do you mean she's killed? She's like, well, she doesn't have any of those symptoms she was exhibiting when she was in the States, those sort of dementia related type symptoms she was exhibiting when she was in the States. Now she can care for herself. She's fine. She's active. She takes herself around. And I was like, you know, that is so interesting. And so I compared that with my own situation with my uncle and just see how he, you know, he's been responding since he got back into his into that cultural context. And I called, you know, Manka, and I was like, maybe this is something we need to look at. I mean, I know it is not scientific, but it is interesting that, I mean, two different situations that I have not done any sort of, you know, study or anything or asked, you know, a lot of other folks, but I mean, those are just the two immediate interactions that I've had that is just, it's taking me from you know, for a loop. And I was like, you know what, I want to bring this up to the researchers at the university, to Dr. Gagler and Dr. Manka, and just see what do they make of this? You know, what sort of implication the environment have on people who are dealing with you know, early memory loss. You know, I know this is like, you know, this is no representative sample, but just those two really pronounced, you know, examples just you know, give me a lot of things to think about. So you know, maybe Dr. Gagler and Manka can share more about you know, why that is. Maybe I don't know if it's by accident. I mean, it just so happened that way, but you know, that's is real. Thank you.
Thanks so much, Mr. Russell. I guess I would add to the original question a little bit, and then I can comment on the last point. So I think in reality, it might be a combination of all of the above. So a lot of the African immigrant families in the United States, if we look at the demographics, they are the adults, and so most of them have children, and most of them are still working. And so they oftentimes either bring an older adult family member into the home to actually help with child rearing while they are working. And so if this person were to develop memory loss and dementia, then it's challenging for that family to be able to provide the care that they would like to provide, even though we have this cultural expectation of family care. And so at times it might be the best thing would be to send the person back home to the country of origin, where there are other family members who the family in the US can actually pay for their time to then provide care, kind of more round-the-clock care for that family member. So I think that's one of the things that could be playing a role into this. And like LaBelle was saying, there's also stigma related to when you do something like that, or if you're sending them to a facility. But the other aspect of that is that we find that a lot of African immigrants that came to the United States in the 70s and 80s typically came for, outside of the refugee populations, came for education and better opportunities. And so their mindset was, I haven't done the research on this, but this is a lot of anecdotal evidence that we're talking with a lot of community members and community from different countries. We find that their mindset was, I was gonna come better my life and then go back to their country of origin. And so their long-term goal was always to retire and go back home. So they would come to the United States, work and build. For some, it was like mansions in their countries of origin. And so their long-term retirement plan was actually always to go back home. So at times, like Mr. Russell was saying, sending somebody back home is actually just fulfilling their wish of sending them back home or fulfilling their retirement plans. And then I'll turn my attention to the comment that Mr. Russell had about people changing. I think what we find with conditions such as dementia and memory loss is that the diagnosis of it is very complicated. So it could be that somebody's experiencing memory loss from a different cause that could be misdiagnosed as dementia. And so what we find is that if the person gets exposure to some sort of other treatment or something, it changes. But I feel like what we need to do as a researcher And as I told Mr. Rosso on the phone, is that I have to still do my research, because for somebody to have dementia, truly diagnosed as dementia, we know that is a condition that has no cure, so they cannot really be cured. They could get better, as some evidence shows, along the disease course for different reasons, but there's a lot of research that still needs to be done, and I guess in him and I will be talking a little bit more about that and observing these two particular situations as we go along to see how things change. And I'll also be looking at evidence in the literature to see what is said about that. And hopefully maybe in another conference next year, we can begin to talk about those kinds of things as they change. And then the next question we have is, do you see the stigma of dementia and mental illness declining in the younger generation of African immigrant families? That's a tricky question, because I have Mr. Russell shaking his head saying no, and Ms. LeBaud mentioned this a little bit about how some of the younger generation were actually the people in the homes with the older adults. I think it really depends on the education. What we find is that in homes that have access to education and in healthcare professional homes, there might be differences, but I'm thinking that because there's a general stigma in the community, in my personal opinion, it would not be different just for the younger generation, because the culture within a home also plays a role on what is accepted versus what is not accepted. Okay, the next question is there a difference in the incidence of dementia or memory loss in Africans living in Africa versus African immigrants in the United States? That's a very good question, and unfortunately, I don't think there's a lot of data on dementia in Africans, either in Africa or in the United States. And that's one of the reasons why we're doing this project, because we really don't have any data on incidents. And like I was mentioning earlier, what we're finding is that the life expectancy for a lot of people in African countries was lower, was very less. And it's only now that with the modern technology that we're having people living into their 60s and 70s that we're having to now begin to think about age-related conditions such as dementia, memory loss. And then the next question is it difficult to find a family in countries of origin to care for those being returned for dementia care? And I can answer this, and any of you all can chime in. So I think what we find is that we haven't done the research on this, but the anecdotal evidence is that it's easier to provide care in the country of origin. It's easier to provide supportive care, I should say, not health care. It's easier to provide supportive care because what we find is that family members who are living in the United States are able to provide finances to pay for an in-home caregiver to provide care at a relatively cheaper, because for most African countries, the exchange rate between the US dollar and whatever currency is much more higher. So to provide care for a family member back home in a country of origin could cost maybe $200 to $300 a month, whereas to provide that same amount of care in the US would have cost more. And so it's easier then to provide kind of the supportive care with activities of daily living. But when it comes to medical care, that's where it gets tricky. So if a person with memory loss or dementia were to have some other kind of medical condition, for say, let's say in my country of origin, Cameroon, and if they really needed tertiary care, there's very few tertiary care hospitals in the country. And so then it would be more challenging, because to be able to travel from my region of birth, which is Bamenda, to where the next best tertiary care hospital is, it takes a lot of travel time, about 7 hours. And so the challenge is that by the time you drive that person from wherever they are to wherever the care might be, you know what could happen in the process. Maybe there'll be the loss of life because of the transportation and all of the issues that happen. So yes, it's easier to provide supportive care in country of origin because it's cheaper, but it's not as easy with medical care because of the limited infrastructure. Do any of you want to add to that? Sure.
On the aspect of care as well, back home in the family of country of origin is easier because when we talk of family in the African context, it's not just necessarily the mother, father, child. We're talking of aunties, uncles, cousin, 10 times removed. So when there's this problem within the family, you have relatives coming from far and near just to provide care. There have been instances where an aunt of maybe 60 years old might just move in and said, my uncle needs my help. And she starts taking care of him. So there's a lot more help with extended family members. So there's always someone watching over the person 24/7.
Thank you, Labelle. And the next question is, I have many elders who are often caring for young children who are clearly struggling to care for themselves. Education is so important. So grateful that you're out there. Oh, thanks for that comment here. And the next one is there, could those returning to their country of origin be doing better due to what is more familiar to from long-term memory, as well as more consistency in the care in the community back there versus in US with a house with children and parents and busy schedules? I think that could be true, like Mr. Russell was saying, how his uncle was tapping into his long-term memory and not short-term memory. But it just really depends on the circumstance, and what we're finding is that families do what's best for their family. And so most families, before they send a relative back home to the country of origin, is actually a family decision that they sit down and have, in-depth conversations. I bet you, Mr. Russell, you all probably sat down and discussed what was the best thing for you to happen to your uncle, and then.
Yeah, I mean, for sure. We had several family meetings, and like I said, I mean, the main thing that prompted us to make the decision to send him back was because it was difficult providing the supportive care for him here, and the only person who had the capacity to do that and the ability to do that was his ex, and it didn't turn out well. So so we made the decision that, I mean, it would be best to just send him back home, and especially that's what he wanted to do even before he got can we say a bad type situation. That was what he was decided to do and anyways. But I mean, you're right. I mean, like what LaBelle said and what you said too as well, is way cheaper. Don't even compare. Cheaper providing supportive care there, and very decent, quality supportive care there. But medical care, that's a whole different story.
Thank you so much, Mr. Russell. And I think the other point that I would like to highlight is that oftentimes in the US context, healthcare is a personal decision, and so people decide what they would like to do or what would happen to them. But for a lot of racial and ethnic minorities and also immigrants, what we find is that healthcare it's a family decision. So there's some things that, we have what we call gatekeepers, where there's somebody in the family that has to give approval for some sort of health procedure or something to happen. So that's something that is very common in a lot of racial and ethnic minority communities, where healthcare decisions, even though it's about one person's healthcare, is made together as a family. The next question is, a problem with neuropsychological assessment and diagnosis of dementia is a lack of appropriately standardized measures for persons from different cultures. And I would just have to say, I wholeheartedly agree with that comment, because a lot of the instruments that we're using to, especially the self-report and observed self-report measures, are things that have not been validated in a lot of racial and ethnic minority communities. So we worry about if they're actually giving us true responses and true states of disease or true states of symptoms and disease in these communities. So I agree. While we're waiting for the next questions, we can talk about our next steps. So like we're talking about, we have done the qualitative phase to really understand the experiences. We took those results from the experiences and we have developed a survey, which we just launched this month and we're implementing in the community. And again, it's really to get some data on prevalence and incidence. It's not a big survey, so we're just kind of starting this process to understand in a larger sample what's happening with memory loss and needs and assets in the community. But the other thing that we're doing, which was something that we heard right early on from our project advisory board and we saw from the results of the community conversations, was the need for dementia education. And so we, Mr. Russell, Dr. Gogla and I came together and were able to get a small pilot grant from another grant funding agency to develop a culturally tailored dementia education for the African immigrant community. And so that's something that we're actually working on now. And like the African Immigrant Memory Loss Project itself, it's also community informed and community engaged, and it's being guided by a project advisory board. So those are the two things that we're working on as next steps for this work in the community. And we just wanted to say the Memory Loss Project was funded by the Health Disparities Pilot Grant from the University of Minnesota Medical School Program in Health Disparities Research. So thank you all for your time, and we'll see if we have any other questions. No, we don't see any questions coming through. So thank you all.